Excellent. Well, hello everyone and welcome to this webinar provided by the International Society for Quality of Life Studies, better known as ISQOLS. My name is Jill Johnson. I'm the Executive Director for ISQOLS, and we are thrilled to have you all joining with us today with Dr. Stephanie Rousseau from New Zealand. Stephanie, is tomorrow, February 10th, where you are, 11 a.m. So depending on where you all, we always like to have people, if you wouldn't mind, just popping in the chat bar and telling us your name and where you're from, just so the presenter can get a sense of who's joining us today. I'm located in the United States in the state of Arizona, in Gilbert, sunny Arizona. So be glad to see where you are all joining us from. And just a couple of things before we get started. I want to remind everyone that this is being recorded and we will be posting this up on our YouTube channel. We actually, for several weeks after the webinar, we posted on our membership forum, which is accessible to all of our members. If you are not a member, we encourage you to join. It's only 75 USD or 50 USD for students and retirees. Get a whole host of benefits, including access to our membership forum and a big discount to our upcoming conference. While we're on that topic, I'll just do a plug for that. We do have a conference coming up in August, the beginning of August, Mont, USA. The deadline for abstract submission is actually next week, February 15th. So you only have a few days. If you haven't yet submitted an abstract, please consider doing so. We do have a topic on COVID-19 and well-being in addition to a variety of other topics. So please check that out. We'll be sending some more details after the webinar. I won't take up too much more time right now. I'll turn this over to Dr. Rousseau to give her presentation. Dr. Rousseau, all yours.
Oh my goodness, thanks, Jill. So this is a paper that we conducted. We finished the study last year and August. The paper is forthcoming in PLOS One, but it is still very relevant today when we talk about vaccines and COVID-19. So this entire paper, it's done by Talita, Greiling and myself, and we're sort of the yin and yang. We can't work without each other. And this is a series of papers that we did using big data, focusing on Twitter. Last year, we published 5 papers looking at happiness across countries and COVID-19 and lockdown and regulations, all using big data. And this is a continuation of that. But instead of just focusing on lockdowns or regulations, we started thinking about vaccines and the attitude towards vaccines. So this is titled Positive Attitudes Towards COVID-19 Vaccines, a Cross-Country Analysis. We'll run through the introduction quickly. We'll discuss the aim of the paper, the literature, very short, contributions that we made through the study, the data that we used, the methodology applied. We will look at the results and discuss them, and then we will finish with some conclusions and open up for questions. Why is this changing itself? COVID-19, so the introduction, what do we know about COVID-19? Well, everybody is aware that it severely impacted world health. There's significant loss of life, but it also irreversibly damaged the world economy. Now, we know that the COVID-19 vaccine is the most successful measure. It's not the only measure that we have to combat COVID-19, but it is the most successful one. Why? Because we know it saves lives. It prevents serious illness. But on top of the saving of life and the serious illness, it does have societal benefits and economic benefits. We are social creatures, and we all found lockdown it was very bad for everybody because we need to be with people. And having the COVID vaccine allows us to interact, and I don't know why this is changing itself, sorry. Allows us to interact with people, to find our friends and our families, and have that attachment that we thrive upon. The economic benefits, we can go back to work, there's tourism, international travel, entertainment. Currently in New Zealand, our borders are still closed. We can't wait for our borders to open up so that we can have our international travelers back, because we are a tourist-driven nation. So what is the problem? Vaccine hesitancy is the problem. It is absolutely rampant everywhere. And last year, the World Health Organization named vaccine hesitancy as one of the top 10 threats for our global health and economic recovery. Now, the problem with vaccine hesitancy is it delays the acceptance of the vaccine, even though it is readily available. Therefore, governments worldwide face the significant challenge on how do you create a positive attitude towards the vaccines and therefore increase the vaccine uptake. So last year when we conducted the study, this is what the stats looked like. For our study, we chose countries across both the northern and the southern hemisphere. And the countries from the southern hemisphere that we used is New Zealand, South Africa, and Australia. And for the northern hemisphere countries in our study, it's Belgium, Germany, Spain, France, Great Britain, Italy, and the Netherlands. And last year when we looked at the stats at the end of July, what we could see in terms of the total number of people being vaccinated was that the northern hemisphere countries in our studies outperformed the southern hemisphere countries. When we looked at the two hemispheres separately, we saw that in terms of total numbers of people vaccinated, New Zealand fared the worst. But in terms of percentage of vaccinated as a share of your total population, we saw that South Africa is much worse than New Zealand with only 5% fully vaccinated. In terms of our northern hemisphere countries, the one that fared the worst was France with 48% fully vaccinated, and Belgium was the one that did the best with 60% fully vaccinated. Oh. When we rerun the numbers again for the end of January 2022, the picture does look different than to what we worked with in July 2021. We saw now that the Northern Hemisphere did not outperform the Southern Hemisphere, but in terms of the Southern Hemisphere, South Africa still faced the worst with only 27% fully vaccinated. Now in the Northern Hemisphere, Spain was the top performer with nearly 82%. And the worst performer was Great Britain with almost 71% fully vaccinated. Then yesterday, when we did our studies, when we did this study, boosters wasn't really in the mix. There wasn't a push to get your boosters. There were third, fourth, wherever we are now with boosters. So yesterday, I just quickly went to our world in data and I just pulled up the data for our countries in our study in terms of boosters administered per 100 people as of the end of January this year. And as you can see, Belgium fares the best again, followed by Italy. The country in the Northern Hemisphere that does the worst in terms of boosters now is Spain. In the Southern Hemisphere, Australia, of course, best performer, and South Africa is nowhere really in terms of boosters. So what was the aim of the paper? Well, we constructed a vaccine positive attitude index, specifically because we wanted to see what is happening with the positive attitude towards vaccines. We wanted to see the trend across the hemispheres and across the countries. We wanted to compare them. And then we wanted to determine those factors that are related to our vaccine positive attitude index that, when possibly addressed, could increase the uptake of the vaccine. For the literature, it's impossible to get all of the literature that now focuses on vaccine, COVID-19 vaccine-related topics, or using Twitter. It's like trying to catch the wind. There's just too much. I want to say every day, there's new studies coming out. But mainly what those studies do is they analyze vaccine-related tweets, similar to what we do, but they focus on the topics that gets tweeted or just the topics and don't do any further analysis. They look at the misinformation that's being spread, the accounts that often very much and try to track them over time. And they also highlight prominent themes that comes out when vaccines are discussed. And what they see is misinformation, vaccine safety, efficacy, conspiracy theories, mistrust in scientists and government, the lack of intent to get vaccinated, your freedom of choice, and of course, your religious beliefs come out. So what was our contribution to this significantly increased area of study? Well, we're the first one to go and create a vaccine positive attitude index using big data, which is an almost real-time measure of attitude towards the vaccines. We constructed high-frequency daily panel data derived from the underlying sentiment and the emotions of the tweets for various geographical regions. We did a cross-country analysis of the trend in positive attitudes towards vaccines, and then we incorporated other data sets to determine those factors that are significantly related to the attitude towards vaccines using econometric modeling. Our data set and our time period. So the time period that we studied was 1 February until 31 July last year. And we chose 1 February because prior to that, sorry, there's a fly. Prior to that, not all of the countries in our study started their vaccine rollout. And in order to construct our vaccine positive attitude index, we used Twitter data. But because we started extracting live tweets for all of those countries, we started extracting the live tweets for South Africa, Australia, and New Zealand. We started that in the beginning of 2019. And in the beginning of 2020, we extracted all of the tweets, the live tweets with geo tags for our Northern Hemisphere countries. It sits with us in our GNH.today project. So that's why we source it from there. And the factors that relates to the attitudes towards vaccines, that comes from also the GNH.today project, but we also use the Oxford's COVID-19 government response tracker and also the Google's mobility reports. So how did we go about constructing our vaccine positive attitude index? Well, as I mentioned before, we harvest vaccine-related tweets at real time from Twitter, which we house with our GNH.today project. The keywords that we used include what you think normally, vaccinate, vax, all of the names of all of the vaccines that are out there. Now, in order to go and establish whether the vaccine-related tweets that we extracted actually do relate to COVID-19, we did topic modeling and we did word clouds. And then we went back to the original tweets to make sure that the words that we use in high frequency actually do relate to COVID-19 vaccines. We use the NRC lexicon to derive the underlying emotions and the sentiment of the vaccine-related tweets. The NRC differentiates between positive and negative sentiment, and it gives you the so-called Plutchik wheel of emotions. So there are 8: anger, fear, anticipation, trust, surprise, sadness, joy, and I can't see the one behind the screen. I can hide that. And disgust. So this is an example of how we went about. So in order to make sure that the extracted tweets actually do relate to COVID-19, like I said, we did topic modeling per country and also word clouds. And this is just an example of the word cloud that we did for Great Britain. And after we did the word clouds and the topic modeling, what we saw is that 90% of the vaccine-related tweets we extracted do relate to COVID-19 vaccine. Now, we do realize that there's a limited noise that gets entered into our data set, but we do not believe that it affects our results, especially because of the significant number of tweets that we analyzed, which was from memory over 1,047,000, something like that. So examples of positive tweets that we got in terms of the VPAI, delighted to lead on conversations around vaccine confidence and debunk myths ahead of Ramadan. Despite my obvious youth and good health, I'm delighted that I got my first vaccine today. Thank you, NHS. Well done to the community reserve volunteers who help at the vaccine centers, all very polite, helpful, and happy. So how it works when tweets get coded using NRC, a score gets assigned according to the frequency and the intensity of the emotion that gets expressed in a tweet. So for example, if we look at this tweet, getting my COVID vaccine tomorrow, and I'm so excited for it, but Jax, that's not my spelling error, that's their spelling error. People can't spell these days anymore. But Jax makes me, and that's very, very, very anxious. I was wondering if anyone, now that's the full extent of the tweet. So the NRC would then assign a 3 to the the emotion anticipation. It would assign a score of 2 to the emotion fear, 3 to the emotion joy, 1 to the emotion surprise, 1 to the emotion trust, and there will be 1 assigned for the negative, the anxiousness, and then a 3 in terms of the positive sentiment expressed by the tweet. So after we have the sentiment, the positive sentiment extracted from all the vaccine-related tweets, we use the mean value per day of all the positive sentiment tweets. We use the minimum maximum method to standardize our index. And after standardization, the index is measured on a scale from 0 to 1, with 0 the lowest positive sentiment and 1 the highest. And as a robustness test for the way that we use the NRC to calculate our vaccine positive attitude index, we derive a similar index, but now we use the lexicon sentiment 140. And all variables are smoothed using a moving average of 7 days. All right, so what did we see? Whether we look at the vaccine positive attitude index in terms of the NRC or on the right-hand side, sentiment 140, we saw that the attitude has a downward trend across all our countries over the time period. And we note that that downward trend is almost 8%. In terms of the vaccine positive attitude index across our hemisphere, we see that the downward trend is there for both the northern and the southern hemisphere, although the downward trend in the attitudes is a bit more severe in the southern hemisphere than it is for our northern hemisphere countries. In terms of the VPAI for our individual countries, what we saw is that the vaccine positive attitude index trends downwards for all of the countries except for the Netherlands and Belgium. And now we resorted back to literature and our topic modeling to come up with possible explanations for either the upward trend or the downward trend in the index. And what we saw from the Netherlands is, sorry, I have to get my notes here. What we saw from the Netherlands is, number one, it was the last country to start its vaccine rollout. And the rollout was also hampered by poor vaccination policy. It had a conservative strategy in place that kept over 40% of the vaccines from being used. But despite that, the government heavily invested at the time of writing this paper, it was 6 million euros on information campaigns and safety of the COVID-19 vaccine. For Belgium, Belgium had a very slow start to their vaccine rollout. But to counter that, the government created a COVID-19 task force to address logistics and capacity issues. Additionally, the Belgian government told the people that they are going to relax lockdowns during spring, but that was dependent on the number of vaccines being administered. It wasn't dependent on hospitalizations or case numbers. And that was an incentive for people to actually go and get a vaccine and be more positive towards the whole idea. In terms of the countries that experienced a downward trend in the vaccine positive attitude index, if we look at Spain at the left bottom of your screen, well, Spain had a delayed government response in tackling the outbreak. They had no workable contingency plans. There was a failure to contain the virus very early on. That nearly overwhelmed their health system. And that also caused that Spain had one of the highest death rates associated to COVID-19. In terms of possible explanations for Germany, why they have this downward trend in their VPAI, a lot of anger came from the Germans, and they were angry about the unvaccinated people being excluded from venues such as the movie theaters, sports venues, restaurants, and so on. They were also very unhappy with the fact that they had to take AstraZeneca, especially after the blood clotting side effect came to light. Great Britain, what happened in Great Britain? Oh yeah, now I remember. Great Britain, when we wrote this paper in August last year, the government still didn't have a plan to vaccinate the 12 to 15-year-olds, even though they were going to go back to school. So there was a lot of criticism towards the government not having that done yet. The so-called, I think we all can remember the Freedom Day they had. A lot of anger was expressed towards the government for actually having Freedom Day. They saw that they were being placed at risk of getting a new variant. people were also angry at other people for not adhering to social distancing or wearing masks. And the side effect of blood clotting and AstraZeneca also played a very big role. For France, there was a very big reluctance to accept the vaccine passports that they rolled out. They were also not happy about having to scan QR codes whenever they go into a specific venue or a retail shops. Side effects played a very big role. For Australia, Australians have this deep-seated mistrust that we found, both in terms of the vaccine and for the government as a whole. Now, Australia is like America. They have a federal-run government, and that means that different states have different lockdown regulations or vaccination mandates, and some don't. So a lot of confusion was created across Australia, and Australians can't understand why the WA still has closed borders, whereas you have Victoria that has experienced 20,000 cases a day, but their borders are open. So they didn't trust that the government were actually making the right decisions, and they also felt that they were pushing the vaccine mandate too hard. There was massive protest in New South Wales, which is where Sydney is, and the majority of those protesters didn't wear masks. So they were all super spreader events, but there was just this, they want their freedom and the liberties back. In terms of Italy, well, Italy was the second worst Northern Hemisphere country concerning people not fully vaccinated. When the government brought in vaccine mandates for the healthcare workers as well as pharmacists, there's a lot of pushback and a lot of anger towards that. And then we all know Italy faced a lot of protest in terms of the vaccine passports and then the subsequent green passes. And the public trust in vaccines decreased significantly after AstraZeneca and the blood clots. New Zealand, well, New Zealand's New Zealand. We're very unique. We're always behind because everything happens in the rest of the world and then it comes to New Zealand. But New Zealand's vaccine rollout has been described as a shambles. And partly it's been a failure, to call it that. I'll call it a failure. Because New Zealand and everybody within New Zealand became complacent. When the rest of the world was experiencing Delta, it wasn't here yet. So we had that time where we could have prepared and gotten our vaccination rollout sooner and get people vaccinated. But because there was the sense of non-urgency, we didn't vaccinate people when we should have. So we had our first Delta case July last year. We went into lockdown again in August. So when we wrote this paper, we were again in level 4 lockdown, which is our most stringent lockdown level. Up until the first half of 2021, we didn't have one COVID case in the whole country. So in that time period, we didn't take advantage. And then when push came to shove and we had to get people vaccinated quick and snappy, they realized we didn't have enough vaccines to vaccinate everybody. And primarily one of the reasons for that is because early on our government made a decision to go with Pfizer and not the other ones. So now we were back in the queue to actually get our Pfizer shipments. There's also, in terms of New Zealand, a lot of pushback for the vaccine mandates, but misinformation in New Zealand plays a vitally important role. Trying to stamp that out, but under certain communities, it's gotten a foothold, and I don't know what we're going to do in terms of misinformation being spread. For South Africa, so many problems and so many concerns that has affected that downward trend in the vaccine positive attitude index. I don't know if you guys remember, but they made news because some corrupt government officials stole the entire COVID-19 fund. That was gone. So there's a lot of corruption, capacity issues, accessibility issues. They had vaccine, vaccine fatigue. They have a lot of misinformation as well. Anti-vaxxers are rife in that country, but there's no trust in the government and there's no trust in the vaccine. So that all affected this downward trend in the vaccine positive vaccine positive attitude index. The covariates that we included in our analysis, we gauged from the existing literature, either papers looking at vaccine and Twitter or separately. We used our theoretical models, our topic modeling, and we analyzed the tweets that got coded as having a negative sentiment so that we could see the major issues that limit the uptake of the vaccines and which are likely related to a decreased positive attitudes. And then lastly, like any other study, availability of the data. So an analysis of tweets with negative emotions. This is an example of a word cloud from South Africa. And I think everybody, can you see the word die? It's right top right of COVID. Left to COVID is kill. Right bottom is dying. So what we found is very interesting that when those words, the frequency of those words, we go back to the content, it's actually not to do with being scared of dying because of the vaccine that you're going to receive. It's actually you're more scared of dying or the economy is getting killed, but it's got to do with the fact of accessibility or procurement or enrollment issues, and that you're afraid you're going to die or miss out because you can't get the vaccine, even though you want it. Examples of negative tweets. For example, we are bored about corruption, poor vaccine strategy, terrible national government, incompetent cabinet, stealing during a pandemic. The vaccine rollout has been disastrous from the government, has cost lives. Now another lockdown, killing our already hurt economy. Massive changes needed in the running of this country. So just a few examples of what negative sentiment tweets look like. So after the analysis of negative tweets, vaccine-related tweets, and we did this for all 10 countries, what we found is that there are a variety of reasons why people express a negative sentiment towards the COVID-19 vaccine. And it ranged from anger towards governments, incompetence in procurement, the lack of procuring sufficient number of vaccines, the execution of the vaccine rollout, fear regarding side effects, definitely there. Fear of people dying because they cannot access the vaccines. Anger expressed towards people who do not intend to get vaccinated. And like I said previously, the words death, dying, killing are more to do with not receiving this, the vaccine rather than fear of side effects. So in terms of our descriptive statistics, so here is the variables that we used in our analysis. So all of the variables were lagged for either possible endogeneity that could arise from confounding effect or bias spreading from reverse causality. So our trust in COVID-19 vaccine. So our trust in COVID-19 vaccine is our proxy for how people perceive the safety of the vaccine. And we use the NRC lexicon to return the emotion score of trust for each COVID-19 vaccine related tweet. Then we constructed a daily time series by averaging the measured value of trust per day. The stringency index and the residential mobility data, those two variables we used to calculate our compliance variable. So the stringency index comes from the Oxford COVID-19 government response tracker, consists out of 9 indicators ranging from closure of schools, closure of work, and it ranges from 0 to 100. The closer to 100, the more stringent your government policies. The residential mobility data we got from Google's mobility reports, and here specifically we looked at the change in duration from the residential category. Our compliance indicator is the one that we first constructed in a paper that we did with Francesco Sarancini, Kelsey O'Connor, and Chiara Peroni, where we looked at the relationship between trust and compliance. And what we did there is we calculated compliance as the degree of association between people's behavior, so the stay, the change in the residential stay, and the COVID-19 containment policies. Then we have an interaction variable, anger towards the government, interacted with daily vaccinations. Now, this variable captures anger expressed towards the government given the number of new vaccinations. It's also a proxy that we use for people's dissatisfaction, expressed in terms of vaccine enrollment, procurement issues, capacity issues, corruption, accessibility. We have vaccine tweets. So those are the total number of vaccine-related tweets. We use the log in our model, and that's a proxy for the prominence of vaccine as a conversation topic. Our new daily vaccinations is our proxy for how well a country is handling the vaccine rollout. Now, we note that the vaccine positive attitude index and our daily vaccinations have an inversely proportional relationship. So therefore, we transformed this variable using a hyperbolic function. And then our new daily cases is a proxy for the evolution of the pandemic across our countries. And we like this variable to capture people's expectation of the trend of the pandemic. And then lastly, we controlled for the vaccine policies, which can have one of 5 different categories that your vaccine policy fall in. We control for vaccine policy across all countries. So in terms of the methodology, what did we do? So to account for the possible confounding effects, and when we talk about confounding effects, what do we mean? Confounding effects such as the severity of the pandemic, the exposure to social media, emotional well-being of the people, accessibility of the vaccine, the prejudice built into the social cultural environment. So to account for possible confounding effects, we resorted to various econometric techniques. Now, ideally, we would have liked to estimate the following equation, where vaccine positive attitude index CT is the vaccine positive index for country C on day T. Our vax trust is the average level of trust related to the COVID-19 vaccine. Government anger is the average level of government anger towards governments for country C on day T -1. Compliance is our average level of compliance, taking into consideration the stringency index and residential mobility data. We have a vector of variables. Lambda are our month effects, which captures common effects across the countries, such as seasonal effects, evolution of the pandemic, or holiday seasons in July. Then we have mu, which is our country effects. So this specification addresses many potential sources of bias. So for example, we've got reverse causality. Reverse causality is lagged by trust, is reduced by lagging trust in vaccines, compliance, anger, government, vaccinations, and cases. Omitted variable bias, both observed and unobserved, related to country characteristics, is addressed by including fixed effects. New vaccinations and cases capture the country's specific time varying evolution of the vaccine uptake and the severity of the pandemic. Our month effects capture the common effects of certain months, like I mentioned, seasonal effects, holiday seasons, the trends in the pandemic. Endogeneity, we addressed with IV regressions. We use the general methods of moments due to the efficiency gains derived from using the optimal weighting matrix. And that addresses bias spreading from reverse causality. In order to do that, we lagged our instruments that we used is we lagged vaccine trust with fear of the vaccine, disgust of the vaccine, and we had a 2-day lag in compliance. We used the Jansen's J statistic to test for identifying restrictions, and as you can see, the joint null hypothesis is that the excluded instruments are valid. So the results. So we did a pooled RLS, fixed effects, and IV regression analysis. So what we can see is, number one, from our trust, is that we can see it is statistically significant and positively related to the VPAI across all models, which means that when trust in the vaccine increases, the positive attitude towards the vaccine improves. In terms of our compliance variable, we note that it is statistically significant but negatively related to the VPAI. Now, this variable, I can tell you, we tested it every which way that we can, but it remains negatively related to the positive attitude against the vaccine. So we interpret it as such. When people are unwilling or they don't really want to comply with health orders such as social distancing or wearing masks, then they would be more willing to receive the COVID-19 vaccine, because with that comes associated freedoms in their minds, and therefore they have a more positive attitude towards the vaccine. In terms of our IV instrument, anger, and daily vaccinations, we see that when people's dissatisfaction with the government increases, the positive attitude declines. And from the tweets that we analyzed, we could see there's a lot of anger expressed towards procurement issues, rollout, corruption, capacity issues. In terms of the daily vaccinations, we see that the relationship between the VPAI and the number of daily new vaccinations is inversely proportional and positive. So that implies that when the daily new vaccinations administered are very low, positive attitudes are high, but as the daily new vaccines administered increase, the positive attitude starts to plateau. In terms of our new daily cases, which was the proxy for the evolution of the pandemic, you can see it's statistically significant and negative. So if the daily cases are high, the positive attitude towards the vaccine is relatively low, but as the daily cases starts to decrease, the positive attitude towards the vaccine increases. In terms of our total number of tweets, we see that as the total number of vaccine-related tweets increase, the attitude towards the vaccine policy, vaccine decreases. From our topic modeling that we did in terms of the tweets, we saw that tweets were related to the long-term effects of COVID-19, conspiracy theories, of course, dissatisfaction expressed in terms of vaccine passports, green cards, there were access issues, name it. And then lastly, what you can't see is that the vaccine policy that we controlled for showed that if more groups can access the vaccine positive attitude index would improve. So what does it mean in terms of our conclusions? Well, what did we find to conclude with? Well, we saw that the VPAI trended downwards, except in Belgium and in the Netherlands. The factors that can improve the positive attitude towards the COVID-19 vaccines are information, and that's information related to safety, as well as the expected side effects of the vaccines. Trust needs to be improved, trust in both the vaccine itself, as well as in government, trust that the government can procure the correct vaccine, the correct number of vaccines, and have an effective rollout. Then we have to look at regulations. Before the regulations get implemented again, they should review it, because we find that there is this way up that people do between the benefits of being vaccinated and adhering to health-related regulations. In terms of social media, we found that communication is vitally important, especially on a platform such as Twitter. They could launch targeted campaigns to educate people about the safety and efficacy of vaccines. They could provide updates about the rollout, how it's going, if they're running into trouble, just be transparent, and then encourage people of all ages to go and get vaccinated. In order to increase the vaccination rate, if one of the problems is getting to hard-reaching communities, they could go the route that United States of America did, and that is to establish mobile vaccine stations, buses, or whatever they have, and go to those hard-hit or hard-to-reach communities to ensure there's no accessibility problems. And then other incentives should be given to vaccinate, not just for you not to get sick or die, but it should be given as an idea that it's the benefit for the whole community. I heard on the news not so long ago, 2 or 3 weeks ago, the South African doctor that discovered Omicron was on our news, and she was speaking about mask wearing. And she said, well, everybody knows that mask wearing is not going to really stop you from getting the disease, but wearing a mask is how I show that I care about you. And I thought, wow, that's a nice way to see it. You don't wear a mask. Nobody likes wearing a mask, but you do it because that's how you show that you care about your fellow man. So what does that mean for our policymakers? Well, in terms of building trust in the vaccine and thereby decreasing fear, they have to disseminate information regarding the vaccine more openly and in layman's terms. They have to acknowledge that fear, anger, and any other negative emotion towards the vaccines exist. They're not going to go away. In New Zealand currently, parents don't want to vaccinate their children. There's a significant fear that you don't know what it's going to do to your child. But they have to acknowledge that. Don't try and shove it away. But at the same time, they should bring people in that can be trusted, not a government official, somebody that the people know and can trust, and talk to them about the safety and the efficacy standards that the COVID-19 vaccine goes through, and that no person will approve children getting vaccinated if they are not sure that it does not have any long-term negative effects for them. I mean, many people's got children that come up with the standards. To build trust in the government and thereby decreasing disapproval and anger expressed in terms of the government, they have to be transparent, more transparent in vaccine procurement and rollout process. We just had this issue in New Zealand with RATS test, the rapid antigen tests, in that for a minute, it looked like the government procured all of the RATS tests that was ordered and shipped here by private companies. So all of a sudden you had government saying, oh, don't worry about it. We've got enough RATS tests for everybody in New Zealand, but it's not them that had it. The private companies had it. So if they were more transparent in the way that they got it, there might be an increased trust in the government. So transparency is key. They should be alert that compliance to the vaccine is being weighed up with having the actual vaccine. So compliance, staying at home or wearing your mask, whether you're going to get the vaccine, then you might not have to do that. People should be educated that even though you do get your COVID-19 vaccine, you still should wear your mask and do social distancing, because it's not just the COVID-19 vaccine that's going to stop you from getting the illness, the disease, or becoming less severely ill. They should start to elicit positive emotions. So rather look at your community, your family, rather than just the individual person. And if there are any accessibility issues, they have to make sure that every person that wants a vaccine should be able to get one quickly, and it should be readily made available. Thank you. That's it. Stop sharing.
Great. Thank you so much, Stephanie, for that wonderful presentation. It's a topic that even just a few years ago, we would never have even imagined, and now it touches all of us, regardless of where we are located. So certainly relevant for everyone listening. And this time we have plenty of time for questions and answers. If anyone has any comments or questions, feel free. We do have a chat bar down at the bottom. Just simply click chat or raise your hand, or if you want to unmute yourself. Hi, Carol.
Can we just talk? Hey, Jill.
Yes.
Hi, Carol.
Thanks, Stephanie, that's great. What a lovely presentation and wonderful work.
Thanks.
Just one question I have, because it seems like you really hit on a central issue, which is obviously is trust, right? Trust in the government and trust in the vaccination and blah, blah, the whole thing seems to be a long line. I guess I was surprised to hear the New Zealand story, because even a country where there is high public trust, if you screw the rollout up, it gets eroded very quickly. And people, particularly in the case of vaccinating their children or whatever it might be, right away say, wait a minute, I'm not doing this. So I wonder if you, and I haven't read the paper, I apologize yet, but do you in the paper, or can you sort of rank governments by the kind of level of pre-existing public trust?
Yes, yes, we
and
can.
see if there's any kind of correlation between the outcomes. I mean, was New Zealand, you said New Zealand lagged, that, you know, they were slow, but in the end, was it a successful effort or not? You know, I'm not, you know, it seems like in general, New Zealand has done very well.
We have. First off, there is a wonderful trust data that the OECD just brought out. And in the revision, the revised version of the paper, so we submitted it first to PLOS and it came back from the reviewers. And we incorporated trust data that we got there. So it gives you, we could see the trust, 44 out of every 100 people trust the government, or 39 trusts the government. So we did incorporate trust in that. The problem with that trust variable is not just related to how government now handles the vaccine rollout. It is trust in general, whether they have.
Yeah, no, that's what I was curious about, actually, is that, in other words, even in a country, I mean, I just think it's an important point that you might want to emphasize more, given the New Zealand findings, that even in a country with very high levels of general public trust, the issue of vaccination seems to be a little more complicated. And I'm just wondering if you might, or maybe you do, say something that, you know, they seem to, they kind of go together, but then they don't, right? Particularly if you, the governments mess up. And so that even in countries with high levels of public trust, which is not the US, but in New Zealand, you know, a messing up of the rollout can really undermine your effort, and that how that's done, and that it needs to be done carefully and in a timely manner and all these things.
Yep.
You know, I guess you can't stress those things enough, but it was really interesting to, I mean, I didn't even know New Zealand had any problems. I assumed it was all fine because everything else has been fine with COVID there compared. I mean, you don't have anti-vax protesters on the street, and
we do now. We do now.
Maybe you do, but you don't have the prime minister saying you should drink Clorox. I mean, you know, the level of Do you see what I mean?
Yes, but so, we did emphasize that in the paper, and it's absolutely true that you say that when you have the general public trust, but when it comes to a thing like a pandemic, no government really is worked with a pandemic. So you either get it right or you get it wrong. And you will be known as getting it right or getting it wrong. And because New Zealand, they really did lag behind in getting us vaccinated. People didn't trust anymore what they're saying. And because there was that small foothold into trusting the government, the anti-vaxxers and the misinformation just went to town on it. That COVID is not real. All of the vaccines that are bringing in is lining the government pockets, and people
Canada
will
has
not
that problem
stop.
now. Canada
They won't stop believing it. Currently, we have the same, not exactly the same, but our beehive, which is like your White House, we call it the beehive in Wellington, it's been occupied. This is day 3 of protesters across the country refusing to go because they will not vaccinate their kids. And the rhetoric that they shout is just ridiculous. Conspiracy theory after conspiracy theory, and Jacinda is a terrorist, and we're talking, the problem, sorry, I'm talking a lot. The problem is that misinformation highly affects a specific group of individuals, and that's the minority and the most vulnerable community. And it's gotten a stronghold in that community. So when we do have Omicron, that's gone, well, we do have now, but when we have the massive outbreak, those communities that are hard to reach, both in accessibility and regional geographic location, that still smoke, don't exercise, that really need the vaccine, is not going to have the vaccine, and they will end up in hospital. It is a,
you know, you should read, there's an old paper about the Pfizer. There's a paper, I think that actually a dissertation fellow or a postdoc at Brookings wrote. She's at Columbia, really, really, really good economist, Belinda Archibong, but on a vaccine trial, a Pfizer vaccine trial for, it wasn't COVID, it was well before, but it was on, it was they kind of botched the trial and they lied about it. And that meant that the actual take up of the vaccine, it was a child vaccine and it was an important one.
Yes.
I wish I remember which it was, but
I'll
not
look.
only did it undermine trust in the vaccine, but that was the effect was strongest in the minority communities that already had less trust in the government and where they were. So I can send it to you. I'll send it to you. I have it.
Thank
in
you.
my files, 'cause
I think
it fits your story somehow.
I think that the missing link between that is you often find that the minority communities already have a trust issue because of the way they've been handled, marginalized, pushed out, land taken from them. So they don't need a lot of reason to mistrust the government when it comes to them saying vaccinate. Oh, it's been 11 months, get your booster after 11 months. And then they say, no, get your booster 6 months. No, we're pushing it to 4 months. No, now it's 3 months. So they're asking themselves, but I don't trust you in the first instance. And now you keep on changing the messaging that you're sending me. So I'm not going to trust you and I'm not going to do this. So there is that you have to focus on how you're going to improve the trust between those minority vulnerable communities and government in order for them to actually take this opportunity and vaccinate before it's too late. And we've been throwing money in New Zealand at this problem. Last count, it was over $200 million that they spent. We actually also have buses that go to these vulnerable communities to vaccinate them, but they get vandalized and the staff gets abused. So
they blew it already, which is what
it's too late.
No, I think it's just a really important point about the whole trust issue and how the initial rollout sort of sets the stage.
Yes,
and
agreed.
I mean, I don't know, that struck me in the presentation among many other things, but I'm really glad that in the revised version, you're sort of dealing with the trust issue and how general trust and then trust in the vaccines is different. And I guess, I don't know if you deal with the fact that it's more likely to happen, the distrust among communities that already don't trust the government or have been mistreated by previous governments are much more likely to backfire. And I think we certainly have that in the US, for example, among African Americans who rightly so have been they've been the wronged victims of experimentation. And so you see a lower rate, even though, a number of other markers, African Americans are more hopeful and more trusting and more optimistic than whites, than low income whites anyway. But anyway, really, really enjoyed it. And thank you very much. Really great.
Thank you for listening.
Thanks, Carol. Any other questions?
Well, I'm not sure exactly what question. It's this is really very informative, and you've done an excellent job presenting.
Thank you.
Actually, the study is extremely seems like it's extremely well done. I'd love to actually see the paper if you've written it.
Yes, I'll send it to you.
Yeah, thank you.
Me too.
Vulnerable population trust issues. At least in the United States, we have some sort of a confluence between vulnerable populations and political affiliation, in the sense that those people who have political leanings to the right of the political spectrum seem to have a big problem with trusting the government and anything to do with the vaccine. So did you look into this, I wonder?
No, not at all. But that's a great aspect that we can follow up on. I mean, this is just the beginning. We can't keep up with the number of new ideas that we get from one paper, which FYI, if anybody's got a postdoc that they want to send to us, please. We've got money, we'll pay them good, but we can't keep up. It's just a little on myself, and there's so many papers that has to be done. But that is definitely something we will look into the future. Thanks, Brooke, for the idea. Because I want to say it's the same year. You find those same kind of people that do not believe in the LGBTQ community, or they parents should be husband and wife and kids, that they do also have the sense of mistrusting the government because they see all of these changes are being pushed through from the government side. And that already changes the trust level between them. So we will definitely go and do that in a paper. Thank you.
Okay.
Yeah, and just to add on to that comment, there seems also to be a trend in those who are maybe unlikely to engage in Twitter. So it'd be, you know, those who have a distrust towards the vaccine might not necessarily post about it on the platform that you're using to gather all this data, but there's also mistrust here amongst those users of Twitter and those other types of social platforms as well. So we do have another question from Annie, who actually had to jump off, but she asked, do you have full access to the data on individual level? And what information do you have about each tweeting person?
All right, so that is the problem always when working with big data. We don't have, I think what Annie means is, for instance, if I tweet, do we know that I'm female and we know that I live in Auckland and I've got an income of, they pay me a pittance. So I've got an income of $100 a week. Do we have that individual level of data? No, we don't. The only thing we can do is have geographical representation. So a paper that we're currently doing with Phil Morrison is looking at the difference between regional happiness and the various lockdown regulations to see how different regions react to that, because we have a geolocation tag. So we can see exactly within Auckland, this person is New Zealand, this person is tweeting from Auckland or Wellington or wherever it is, but we can't tell you who sits behind that tweet, which is one of the limitations when you're working with big data such as Twitter. So no, we don't have that. Would be nice to have that. Future studies is looking into how do we combine big data with our normal survey data. So that is the next step that we're doing. One of the studies that we want to do from next year onwards, which is funnily with Annie, is to look at our indigenous Maori community. And what we're doing is doing survey data to understand their issues that they have with government and trust, and how they see land and sea and forests different than we do. And then we will also have them tell us their stories, and we will be doing a voice sentiment analysis. So we can, from their voice, their narrative, find out how they actually feel about what they are talking about. So we've got many different things in the pipeline, but it's exciting times.
Oh, a tremendous amount of future research possibilities for sure.
Yes.
Any other questions or comments before we close this webinar? Well, Stephanie, I would love if you would be willing to share your paper or any other relevant information. Also, if you're looking for a help, just let us know. We can post that as well. We're glad to send this out, and hopefully we can hear a little bit more about it at the upcoming conference in Vermont. If you're planning,
definitely.
Good,
and apologies for keep on shoving my earphones back in my ears, but I've got two little baby cockatiels that we're hand raising, and whenever they hear me, they just screech so I can get out of the bird cage. So I have to put this in, or else you will think I'm being attacked by birds.
No problem. We didn't hear it at all. No worries.
That's good. Well, thank you so much for listening. I hope you all have a great evening, and I can tell you that Thursday, the 10th of February is an awesome day.
Wonderful. Well, we'll look forward to tomorrow. We're glad it already turned out well for you. Thank you again for this presentation. Thank you everyone for tuning in. Just a reminder, next Tuesday, February 15th is our final abstract deadline for our upcoming conference. So please do submit it. If you are a member, we'll be posting all of these materials on our membership forum. We'll be sending out a notice right after this webinar. So thank you again, everyone. Thank you, Stephanie, Dr. Rousseau, for your presentation, and to Dr. Grayling, we thank you as well for her contribution.
Thank you, Jill.
All right, everyone,
take care. Jill. Thank you. Bye.
Bye. Thank you.